Thank you for joining us today to discuss APRN workforce issues in Kentucky. This presentation was recorded earlier in the week, and the presenters will be live to answer questions following the recording. First, we would like to introduce ourselves. My name is Dr. Julie Osage. I'm an associate professor at the UK College of Nursing, where I teach in the Doctor of Nursing practice program. I'm a family nurse practitioner with over 30 years of practice experience, and I'm currently in my second term on the board of directors of the Kentucky Nurses Association. Dr. Melander.
Thank you, Dr. Osage. Hi, everyone. My name is Sheila Melander. I'm the Associate Dean at the University of Kentucky for the MSN, DNP, and faculty practice areas. I also am an acute care nurse practitioner, and I just finished a term on KNA's Governmental Affairs Council. So, Dr. Estes?
Thank you, Dr. Melander. My name is Jessica Estes. I am a lifespan certified psychiatric mental health nurse practitioner with more than 17 years of clinical practice. At the time of this study, I served as the executive director at the Kentucky Board of Nursing. I currently serve as the chief nursing officer at Alaska Behavioral Health.
The objectives for this presentation are to discuss the Kentucky APRN study that we conducted and its relationship to a national APRN study, to explain looming workforce issues for Kentucky APRNs, and to identify opportunities to strengthen the APRN workforce in Kentucky. For those that may not be familiar with APRNs, which is Advanced Registered Nurse Practitioners, Advanced Registered Nurses, there are 4 roles that fall under this license: nurse practitioner, certified nurse midwife, clinical nurse specialist, and certified registered nurse anesthetist. And we wanted to show you who we're talking about when we say APRNs. And so these numbers represent the APRNs in Kentucky. There are a total of 11,391 APRNs licensed in Kentucky. 7,277 reside in Kentucky, and over 2,000 reside out of state. As you can see, the NPs are the largest group with 9,542. This slide shows the breakdown of the type of nurse practitioners licensed in Kentucky. The majority are family nurse practitioners who can see patients across the lifespan in primary care settings. These numbers add up to more than the total of 9,542 because some people are licensed in more than one population. In Kentucky, all APRNs have independent practice authority, but are limited by collaborative prescribing agreements, also called a CAPA, that are required to prescribe non-scheduled drugs for the first 4 years of practice, and that's the APRNS, or for prescribing all scheduled drugs with no time limit, and that's the APRNS. The CAPAs have been shown to limit APRN potential in several ways. Some of those are explained here. So the CAPA prohibits APRNs from seeing patients on insurance panels that do not also include the collaborating physician on the panel. They limit the ability to prescribe opioid addiction treatment if the collaborating physician is also not a certified medical assisted provider. And some APRNs pay their collaborating physician. Additionally, APRNs need a DEA license to order supplies for the office like insulin, vaccines, antibiotics, oxygen, etc. And these are essential supplies for many ambulatory office settings. In Kentucky, the APRN cannot obtain a DEA license without a CAPA-CS. As we are all aware by now, the COVID-19 pandemic created unprecedented circumstances in the U.S. healthcare system. To facilitate continued healthcare during the pandemic, governors in some states with reduced or restricted APRN practice issued executive orders that temporarily suspended all practice requirements, and that occurred in 5 states, or waived select practice agreements in 16 states. Kentucky was one of the 16 states that waived select practice agreement requirements. On March 31st, 2020, Governor Beshear issued an executive order that suspended collaborative prescribing agreements for the duration of the pandemic. These novel circumstances provided an opportunity to evaluate the impact of the APRN workforce in managing healthcare during COVID-19 and to examine the impact of the CAPA suspension on APRN practice. The pandemic and the executive order provided a unique opportunity to study APRN practice attributes with and without a CAPA, which had never been done before. While examining APRN practice, we also looked at issues specific to workforce. About a year ago, during a KNA board meeting that Jessica and I both attended, we learned about a group of nurse researchers from Vanderbilt and the University of Tennessee who were conducting a study to look at APRN practice during the pandemic. And they were also inviting other states to participate. So I got on my phone, texted Jessica, said, count me in on this, let's do it. And prior to that, a day or two before that, Dr. Melander and I had been in a meeting where APRN practice during the pandemic was discussed. So I texted her about this. She was friends with Dr. Ruth Kleinpel, who headed up the study from Vanderbilt. So she texted Dr. Kleinpel and said we wanted to be part of it. We wanted a Kentucky arm of this national study. And so that's how we all got involved in this project. The Tennessee group recently published results of the national study, and I provided a link on this slide to that article in Nursing Outlook. The purpose of the study was to explore the effects of the COVID-19 pandemic on APRN practice in Kentucky, describe state APRN practice barriers, and determine the effect of the COVID-19 pandemic-related suspension of the collaborative prescribing agreements, or the CAPAs. 690 Kentucky APRNs participated in this study. The majority were female, master's prepared, and practiced in a rural setting. Also, 66% worked in outpatient settings, and these characteristics closely resemble those of the population of APRNs in the state. Dr. Estes is going to review more results.
So in the study, we asked some specific questions as they related to state practice barriers and restrictions that might limit the ability as an APRN to provide care prior to the pandemic. As Dr. Osage said before, there were 690 participants. Those participants identified that organizations may limit the things that are not limited for APRNs in law, such as hospital admitting privileges. 31% of our participants identified that as problematic for them. 24.8% of our participants identified that collaborating or supervising physician practice and population restrictions are a problem. The current law states that individuals who are practicing must have a collaborator of the same and or similar specialty. That creates a unique challenge, as you might be the only psychiatric nurse practitioner practicing in your county, and there's not a psychiatrist there. 15.8% of our participants identified that orders may require a physician or an MD to co-sign. 12% of the individuals that participated identified that prescriptions require an MD signature, even though they have prescription authority. 12% identified that health insurance credentialing was restricted, that there are insurance panels that may limit and or restrict APRN's ability to be paneled. And then 12.3% identified that payment requirements to collaborating physicians or supervising physicians may be a barrier. In Kentucky, many APRNs pay their collaborator a monthly or annual fee to sign that collaborative agreement. Next slide, please. So the executive order issued in March of 2020 created a change in the way APRNs could provide care within the state. 60% of study participants, 259 individuals, reported that their ability to prescribe non-scheduled drugs as the biggest change to their practice. It is important to note that the top response in this survey was not controlled substance prescribing, as the opponents of permanent CAPA removal would suggest. It is also important to note that the removal of the CAPA did not change any of the supply limits that are currently in place for APRNs. The second most common change was the ability to prescribe scheduled drugs. 192 participants indicated that they were able to prescribe scheduled drugs. 130 participants reported being able to accept new patients, while 14% were able to accept different insurances than they had previously been able to prior to the pandemic. The need to have a collaborating physician that mirrors the practice population of the APRN is troublesome for many in this study, given that there are multiple areas of the state with few providers. That restriction further limits access to care in these communities. There is no geographic limitation on distance between that APRN and collaborator. However, it's very unlikely that a physician is going to collaborate with an APRN with whom they are unfamiliar or they don't have working knowledge of their clinical practice. So similarly to what we see in other states, in looking at education, the majority of APRNs in Kentucky have a master's degree as their highest degree attained. Several national organizations endorse the doctoral degree as the entry to practice for NPs and nurse anesthetists have already made this change. There are and or will be implications for academic programs should this come to fruition. The important thing to remember about the Kentucky-related data is that the Board of Nursing does not gather the higher level degree. They only gather the data here as it relates to what gets them to achieve licensure. So for most APRNs, it's a master's degree, and we're not going to be able to adequately attack and to account for individuals who have attained a DNP after that. The mean years to retirement, looking at the range of 1 to 45 years, we've broken this down a little bit further on the next slide. When we look at accepting new patients, this study found that 130 APRNs were able to accept new insurances into their practice due to the COVID-19 related CAPA suspensions. For those of you who have had the opportunity to fill out insurance traditionally, many times they will ask you to put your collaborating physician on that agreement if you're attempting to set up an insurance contract. Not being tied to the insurance carriers preferred by their collaborating physician clears a path to accept new patients. Geographic location creates a health disparity in Kentucky, and one solution could be less practice restrictions, as it's well known in states with few practice restrictions are associated with more APRNs, particularly nurse practitioners providing care in underserved areas, per Beerhouse in 2018. An APRN who can accept new patients when practice barriers are removed is a benefit to the community in which he or she practices, and that benefits the Commonwealth. When we are looking at the years to retirement, it should be noted that nearly 1/3 or 32% of the APRNs in this study expect to retire in the next 10 years. Assuming that this percentage closely mirrors the APRN population in the state, and it does, this is a huge number and could have far-reaching negative impacts on healthcare delivery within the Commonwealth. At this time, I'm going to turn it over to Dr. Melander to discuss some of the workforce implications.
Thank you, Dr. Estes. So in talking about these very important issues, as you can see, we have some major things coming down our way as we look at the future of nursing with our data. We know there's a nursing crisis in Kentucky. The data has supported that. We know we have a national nursing crisis, and national organizations are discussing these issues and trying to provide guidance and next steps. So a part of that, on our next slide, we decided that would be really important for us to talk about is that Future of Nursing 2030 workforce predictions. So we're going to have to bolster national and governmental support to be able to address these issues as they're coming at us. So the nursing workforce represents our largest healthcare professions. We are nearly 4 times the size of our physician workforce. A 2020 report prepared by the American Association of Medical Colleges estimates that by 2033, current physician shortages could increase, and what that's going to look like is for primary care physicians, that's going to range between 21,000 and 55,000. For non-primary care specialists, it's going to look like a deficit of 33,000 anywhere to 86, 87,000. Here's what else is happening in this time frame. Our U.S. population over this decade will have increasing numbers of people aging into their 70s, 80s, 90s, and beyond. So we're going to have these above challenges that we're going to have to work through, but we're going to have some additional challenges within our healthcare systems itself and workforce. So the future of nursing does have some conclusions around these workforce issues. So conclusion 3.1 talks about a substantial increase in the number, types, and distribution of members of the nursing workforce and improvements in their knowledge and skills addressing social determinants of health. There's just a ton. If you haven't had a chance to read the future of nursing recommendations yet for 2030, take a look at that. There's a lot on that, which desperately is needed. We need to look to be able to fill the gaps of care related to demographic and population factors. And these factors include our aging population, our increasing incidence of mental and behavioral health conditions, and the increasing lack of access to primary and maternal health care. Conclusion 3.2 looks at eliminating restrictions. Go back one more, Julie. Eliminating restrictions on the scope of practice of advanced practice registered nurses and our registered nurses as well, so that we can all practice to the full extent of our education and our training. And that just that alone will help us increase the type and amount of high quality healthcare services that we can provide to all that need it, and also help with our access and help us deal with our health inequities. Conclusion 7.3 talks about learning experiences. So we have a lot of work to do here. So with our nursing students, as we prepare to address these gaps, we need to continue to look at health equity, social determinants of health, population health, and identify opportunities to learn cultural humility and for all of us to recognize our own implicit biases. We need to also gain experience with our interprofessional collaboration abilities, learn how to partner better. And then we also need to look at developing some of our technical competencies, such as telehealth, digital health tools, and data analytics. We need to gain some really different type experiences to what we've had before in our schools of nursing, and maybe even for our nurses that are just out of school that maybe haven't had that as well, that are already in the workforce. Conclusion 7.4 talks about successfully diversifying the nursing workforce. And that's going to depend on our ability to use holistic efforts to support and mentor and sponsor our students, our faculty, and our APRNs that are in the workforce. And this has to come about with the inclusion of looking at the environment, providing economic, social, professional, and academic support, as well as in all of our healthcare systems. We've got to wrap our arms around these efforts. Future challenges. So as we've said, we have got to increase the number of APRNs and nurses to be able to meet our growing healthcare needs. We have to right size our clinical specialty distribution of nurses. How do we know what we need in our areas? Have we talked about that? We need to increase the distribution of nurses and APRNs to where they're needed most. Again, surveys to look at this. Where do we need to be deployed? That was a major issue with COVID initially. Ensuring that nursing and APRN workforce is diverse and prepared with the knowledge and skills to address the social determinants of health. And we need to overcome current and future barriers affecting workforce capacity issues. We need to learn to anticipate these long-term impacts of COVID-19. You know, what about the effect on our our delivery chain? We're having issues. One of our hospitals in the area couldn't get distilled water to mix the formula for the infants. So all of these things, if we can try to look ahead, that will help us as we move forward also. So looming workforce issues. We have large number of APRNs, as you just heard, planning to retire in the next 10 years. So Dr. Estes talked about 32%. Well, that's 32% of the 690 that we were able to survey. We know that you heard Dr. Osage say we have over 10,000 APRNs in the state. So that number could be much larger, and we anticipate that it is much larger than that 32%. We have numbers of APRNs that are not sufficient to meet our patient needs. We know right now even our APRNs are getting pulled to the bedside in this time of workforce crisis. So then what does that do for their patients that aren't being seen? We have continued pandemic fatigue without clear resolution. We have large numbers of physician providers that are predicted to age out, as we said earlier. And we have some early retirements that are brought about by the pandemic as well. So those numbers we anticipate will even be higher than what you saw on the previous slide. So opportunities to strengthen our workforce, we would love to recommend that everyone build stronger partnerships, connections, and collaborations between healthcare systems, colleges, and universities that prepare APRNs, especially if our numbers hold true for our predicted retirements. And we've got to build these partnerships with our communities. You know, how do we prepare for those to meet all of those needs if we're not having those conversations? So we've got to do a better job with that. We need to work together to project upcoming needs minimally 3 to 5 years so that we can have a workforce ready to meet those projected needs. Through these established partnerships, we need to have some transparent discussions around the fact, are these graduates ready to assume the responsibilities when they hit the ground? Because we don't want them to have unrealistic onboarding or orientation time. So we need to have some really true, transparent discussions around that. We need to increase our connections with our providers to promote increased understanding of the roles of APRNs so that we can move more towards our full scope of practice. So in summary, Dr. Osage, Dr. Estes, and I, it is our hope that this webinar sparks much more discussion around workforce. We hope this is just the first of many efforts that will start to move us to be at a better place down the road addressing workforce needs for our APRNs so that we're able to meet the future healthcare needs for our patients in the Commonwealth. So that concludes that portion of our webinar where we just wanted to make sure you had the facts and the data from our study. This next section is going to move into some frequently asked questions that's received by our KNA office regarding APRN workforce issues. So one of the first things we wanted to talk about and have information available to all of you is, how can I better support the advanced practice efforts in Kentucky around our APRN workforce? So we wanted to give you the list of the groups that do support and serve as advocates for our APRNs in the state. So that is your Kentucky Nurses Association, your Kentucky Association of Nurse Practitioners and Nurse Midwives, the Kentucky Association of Nurse Anesthetists, and the Kentucky Board of Nursing. And another real strong pitch here that we anticipate additional surveys coming your way to help us meet these needs and anticipate additional needs. So please pay attention to those surveys if they come to you in the near future, and also reach out to your peers to have them participate as well so that we can have the best data that we can get to help us meet those needs. So I want to ask Dr. Osage and Dr. Estes if they have anything that they want to add to this piece about how can our listeners and our viewers better support APRN efforts in Kentucky.
I would say if you're an APRN listening to this, to join one of these organizations, whichever applies to you, one or more, because everybody could join KNA plus a specialty organization. Follow the work of these organizations, volunteer your time, support them with your dues, attend conferences. All of that is really important. All of these organizations are the voice of the nurse or the nurse anesthetist or the nurse practitioner, nurse midwife. So without your input, it's hard to know, maybe impossible to know really what's happening and what you need. So as long as you're a member and you're sharing your needs, then the organizations can serve you better. So I would encourage you to join.
I would also add that the Kentucky Board of Nursing, as the regulatory authority, has open meetings to the public, and I would encourage you to attend both the APRN council meetings and the open board meetings, because that's how you find out what changes are coming down into the pipeline for practice, and you learn about the APRN administrative regulations and the statutes that impact our clinical practice.
That's great. Thank you, Dr. Osage and Dr. Estes. We've listed for you also underneath the next question, how can KNA help connect me with potential partners, healthcare systems, and educational partners, as mentioned in our presentation. So we just listed for you the Kentucky Nurses Association main office number, as well as the Kentucky Board of Nursing APRN Council main number. So the next thing we wanted to talk about is, what is the Kentucky Board of Nurses' role in workforce, and where are those discussions taking place? So Dr. Estes, could you please address this question?
The Kentucky Board of Nursing currently tracks some limited workforce data based on licensure renewal. At the time that you renew your license, there is data and information gathered about your current work location, as well as whether it's a primary or secondary location. The important thing to remember about the workforce data that they do collect is that it's contingent upon voluntary reporting of that information by the licensee. It also does not allow us to easily gather individuals that have moved in or out of the state outside of them not renewing their license, and it's limited by no national standard to be able to track a nurse based on where they're working and how they're working.
That's great. And Dr. Osage, can you talk about the role of KNA in these discussions?
Sure. KNA is the voice for all nurses in Kentucky. KNA tackles issues that are common across the nursing profession. So they also contract with a lobbyist, and part of the dues go to this. And in fact, the lobbyist that KNA contracts with is the same lobbyist that the Kentucky Association of Nurse Practitioners and Nurse Midwives contract with, and the Kentucky Association of Nurse Anesthetists. So we all share that lobbyist. We have a lot of issues that are in common, a lot of issues that overlap between all the professional organizations. But KNA is the one that sort of transcends all of them. Also, KNA has a program called Nursing Helping Nurses, which is a program that started during the pandemic, and there are 81 nurses who have volunteered their time to be a sounding board, a listening ear, a friend to nurses who are struggling. And this really serves to maintain the mental health of the workforce. Sometimes only a nurse will understand the struggles that another nurse is having. So this is a great service that KNA provides.
Thank you so much, Dr. Estes and Dr. Osage. This concludes this pre-recorded portion of our webinar. We just want to thank you so much for all of you attending this very timely, very crucial discussion on APRN workforce to allow us to share the data that we had. And Dr. Estes and Dr. Osage will be joining you now for some live interactive polling questions, and they'll be here also for any further questions you may have or discussions. So thank you so much.
Julie, you're on mute.
I just figured that out. Thank you. I'm going to switch so you can see the slides with the questions on them we'd like to discuss.
And Julie, when it's time, we do have some questions in the chat box, and we'll be ready to ask you and Dr. Estes some more questions.
All right. So this is we're going to use the poll. I'm showing all my technical skills here. So we're going to try this poll. And I'm going to show you, put up one question. So the question is, would you be willing to participate in another questionnaire as we work on advancing our efforts related to the APRN workforce? This is the, one survey. We've got lots of other things that we need to ask, and this data needs to be followed over time. So here's the question. We'll give you all a few minutes to answer that. All right, I'm going to end the poll and share the results with y'all. So thank you for everybody who said yes. Appreciate that. Our next question is about retirement. Do you plan to leave or retire from your APRN position in the next 5 years? Can you see the results right now? No.
Yes.
Yeah, okay. All right, so yes, 29%, maybe 29%, and no, 43%. I know some of y'all are already retired. So that's interesting.
Is that some of the participants, just because I know them, are not APRNs, and so they didn't really have a great place to answer there either.
True. Okay, so our next question, would you be willing to share reasons why you are leaving your practice if it's not related to retirement? And this we don't have a poll for because it's sort of an open-ended question. So if you could put that in the chat box, and you can, when you chat, can you all see my chat right now if on the screen?
No.
Okay, so if you open up the chat and just next to the word everyone, you can select who you would like the chat to go to. So you could put it in for everyone if you want to, but if you'd like to just send it to one of the presenters, that would be fine too. You don't have to send your answer to everyone if you don't want to. So that question was just about sharing reasons why you're leaving if it's not related to retirement. And then are those chats, is that good, you think, Eleanor, or are people still writing?
Nope, I think we're good.
Okay, last poll question. Do you feel you've received adequate support during the past 18 months? Definitely, sometimes adequate, did not receive, and definitely did not. Okay, so the majority were, I sometimes received adequate support, so not overwhelming, but at least overall, it's pretty positive, but I'm sure we do have work to do there. And then the last question would be also one that you could put in the chat box and direct it to one of the presenters if you choose. Can you list anything that would keep you in the work setting? as opposed to leaving. Tell me when you think we're good.
Can give it another minute.
Okay.
I think we're good.
Okay. So what question? Well, okay. So we have our references here. The Nursing 2030, if y'all have not seen that, is this reference, the one on the bottom there. And then we have our emails and KNA website, the Kentucky, I always want to call it the coalition still, KBN, Nursing Helping Nurses, and then the clinic, which Delano, did you talk about that at the beginning, and did I?
I did not. I haven't talked about it yet, but you go for it.
Okay, so the clinic is happening on November 4th at 7 p.m. in conjunction with the KNA Summit, but it is the night before, well, Thursday night. And it is a nurse named Tara Reiners. Let me see if I can pull that up.
And Tara is a dancer. She is a artistic director. She's a nurse. And she is providing currently, actually today is the second day of the workshop, Julie. And we had approximately 20 nurses who volunteered to participate in a workshop for 2 Fridays. And the workshops are going to be focusing on mental health and support for nurses. As part of that workshop, there will be some video components, and then next Thursday, as Julie mentioned, at 7 p.m., we will see the video product from the workshops, as well as some skills that we hopefully will be learning on about how we as nurses can manage and support our own personal mental health.
It's a very powerful, moving production. We saw a version of it, not the one with the Kentucky nurses in it, because there are 20 nurses from Kentucky that are participating in this one next week. But we saw a previous version, and it's very powerful, very moving. It's really intended to help people heal from the trauma of nursing and the daily grind, I guess. So it's really an awesome presentation. I think I encourage everybody to go. So at this point, this point, we would like to answer any questions that you all have. We have about 15 more minutes. So Delano, shoot.
All right. Well, there are a lot of incredible comments that I would like to share, as well as some questions. Kathy Marchand said, this is an excellent presentation and excellent information. Thank you for your work in this area. Looking forward to sharing with colleagues around the country. On the same line of thought, when will you all be submitting your manuscript to the Kentucky Nurse newsletter for publication? You can let me know about that later after the presentation.
It's written.
Oh, good. Oh, good.
But then after we did this, we're like, so we probably need to change this in the article. And so now we're going to tweak it a little bit, but it will be forthcoming, I would say, within the week.
Thank you very much. I am counting on it. All right. Pam Hagan says, has more analysis been done on the patient outcomes of the relaxing of the APRN regulations? Suggest that talking points from this information be posted on the website of all the organizations mentioned. Individual nurses could then access the information to talk with legislators.
Yep, it could be.
To speak to Pam's point in asking the question about patient outcomes, when you think about patient outcomes, it will be really challenging to gather that data. There is one data point, which of course is the CASPR reporting and what those controlled substance prescriptions look like. And when you think about the relaxing of the regulations, there was just a full year of data in March of 2021 that will need to be reviewed and analyzed to determine whether there really was that phenomenal uptick that the opponents of the removal of the CAPA will perhaps utilize to keep it from being permanently lifted.
Excellent. I'm not sure if all of you know that the Kentucky Nurses Association, in collaboration with other nursing organizations, including the KBN and the Hospital Association, did a press conference last Friday. And it was very well received throughout the state. We now have an appointment to speak with the governor, and we will be utilizing some of your talking points and our talking points when we meet with the governor November the 16th. All right.
That's awesome.
We are also going to be doing a letter writing campaign, and we will be asking for your help to send letters to your legislators, and we will provide the talking points for that as well. Okay, Kathleen Holcomb says, many new grads are unable to find positions in primary care because they do not have 1 year experience. Also, studies have shown that 1/3 new grads leave primary care within 1 year. Any discussion about what we can do for these new grads? Julie?
That's a big question. What they can't, the 1 year experience, that's for the CAPA CS. So they can't get a job if they don't have the opportunity to have a CAPA CS. Is that what you're saying, Kathy?
No, many employers don't want them.
Just because
they take on a new grad. Mm-hmm.
Wow.
I don't, it blows my mind. I don't know what people say about that. You know, there is talk now about more clinical
residencies. Yeah.
Which I think, Kathy, one of the things that may help is something that we have in our plan from the Kentucky Nurses Association, and that is to bring back some of our retired nurses. If I remember correctly from the last data that Kelly provided, we have about 5,000 retired nurses that could help us in terms of providing some guidance and support. And maybe that's something that employers would consider in hiring these new nurses, these novice nurses, and then bringing on some of the retired nurses to help support. So just a suggestion. Here's a comment from Sarah Schreimer. Says, hold on, Sarah. It was a wonderful comment.
Even though the CAPA CS has been temporarily suspended, she's continued to pay her collaborator and maintain this agreement because of the uncertainty around the agreement and arrangement and not knowing what to expect once the orders have been rescinded. Does the KBN KNA have any guidance around how to handle this situation? Sarah, I'm going to speak as my former role was as the executive director. We're fortunate enough to have Kelly Jenkins, who is currently the executive director at the Board of Nursing, on the webinar with us as well. In speaking with APRNs, my advice has always been not to cease paying your collaborator, as we do not know what's going to happen with the CAPA in the next legislative session, and they certainly would not want to burn any bridges that might result in them being unable to attain the collaborator once the state of emergency has ended. So we have heard, and I can say I've spoke with a number of APRNs from 2020 to 2021 that had done that, and even had the opportunity to hear from some physicians who were very concerned about the fact that they were no longer getting their monthly fees that were associated with those collaborative agreements. So it's a very challenging situation, and I always encourage individuals not to make any decisions that could result in a problem with your clinical practice going forward and an inability to attain that collaborator when the state of emergency ends.
And from the KNA perspective, it is one of our priorities for the legislative session for 2022. And also it will be a talking point when we get to the governor's office. Don't worry. You know, one of the positives, and Julie mentioned that, is no matter what specialty that you have, if you are a nurse in the state of Kentucky, KNA is on your side. And KNA will speak for you, and we need to hear from you. So, and I also think it's interesting that your survey and some of your survey results mirror the survey results that we did for the KNA regarding nurse issues and workforce issues.
Yeah.
Okay, Melanie Harden-Pierce, I'm curious if analysis of impacts of nurse faculty shortages on capacity of schools of nursing to meet the demand.
Melanie, before we address Melanie's question, Kelly, did you want to say anything about Kelly Jenkins about the last question?
No, I mean, it's the same thing Jessica said, but I will tell you, we are going to have a hard battle, and we do have lobbyists that are working with us going into this next session, but it's really going to take all of our nursing, not just the APRNs, but every nurse that you know to reach out to their legislators, because we've got both co-chairs of the LRC are anti-APRN. So we've really got an uphill battle. So I know I've talked to Delanor about this, and we're really going to have to use our voice, because there are more of us than there are of physicians, but all of the other legislators are going to have to come on our side, because I know there's 3 for sure that are not going to change their mind, and 2 of them are co-chairs.
So in other words, we will not be sleeping much. We will be working.
And any additional data, I mean, now we have some real data, which I think will be helpful. And then when you get to Pam's question, she's talking about more data. So that would be good. You know, I think the more data we have to show people, and so we're not just talking anecdotally during the next legislative session, would be really good too.
And we actually did just run some data through Casper. But I will tell you, every session, there is one senator who brings data that's very old. But we do have new data, and it dramatically shows that APRNs are doing very well with prescription, in particular narcotics. So we have given that to all of the legislators as well.
Good. You can give them all this too.
So Julie, would you like to take on that nurse faculty shortage issue?
Yes, the impacts of nurse faculty shortages on capacity of schools of nursing to meet demand. Big problem. And I don't think there's been any analysis, at least not in Kentucky that I know of. I do know nationally that there's, and I couldn't cite a study, but there's talk of how the nursing faculty shortage impacts the enrollment, basically. And so the outcome of how many people we can educate, it's a problem. And we know that nurse faculty are also retiring. So it's a vicious cycle. One just feeds off the other.
Absolutely. In the plan that the KNA developed in collaboration with other nurse leaders, we asked for $20 million for faculty salaries, to increase salaries, but also to inspire nurses to become faculty. And so that's part of the plan.
Yeah.
I have a question here from Ann Vino. Would be good to work with employers and those doing career counseling to advise students to work with employers and others involved in student clinical placement to assure there's an organized and planful process to assure student placement meet the learning and clinical needs and avoid preceptor burnout.
Amen, sister.
And I think you're totally right there. And what we learned in the pandemic is that the volume of individuals across all disciplines in nursing that could be in clinical and preceptor locations abruptly declined. And then we did not have a great plan in place to figure out how are we going to replace those clinical sites that we had previously using. And I think that's going to continue to be a challenge going forward, because the individuals that are precepting and they are participating in the educational process, we're going to burn them out, because if they keep saying yes, they're going to struggle. And so I just happened to do a presentation 2 weeks ago for the Alaska Nurses Association talking about nurse burnout. And one of the things that they identified in my poll there is that when we continue to ask them to take on more and more students, it increases their dissatisfaction with their positions, and they feel like they're being taken advantage of. So that's something that we're going to have to strategically think about, because if we keep placing those demands on those individuals that say yes, eventually they're going to be unable to or feel unable to say yes going forward.
I think, Jessica, one of the recommendations that we made in our plan, as well as we talked about bringing back retired nurses for to participate in some of these roles, to act as preceptors, and we are planning on that being part of the considerations for implementing the KNA plan. Yes, Julie, did you have something you wanted to share?
Yes, I have had this notion in my head, although I haven't done anything with it. I've said it out loud a couple times, but never got any further. But I think it would be awesome if we had something across the state from all of the schools that educate specifically midwives and nurse practitioners, because I think the CRNAs kind of have their own deal as far as placement, but and healthcare organizations that employ a lot of our preceptors, and sort of try to figure out how to do this, because especially if the new NTF guidelines, the Nurse Practitioner Task Force guidelines, come to fruition eventually, and they're calling for 1,000 hours of direct patient care, and right now it's 600 or 700. So that's more time that we're going to need from preceptors, and I just feel like if we don't have some coordinated system to try to address student placement, we're going to be in a world of hurt, and it's already bad. I mean, as others have said. So I think it's with retirements coming, people getting burned out. We need to have something in place. So I totally agree, Anne, that something needs to be done to assure placements, coordinated placements. Yeah.
I think that's great, Julie. If I could just interject, I think it's all. I love hearing discussion about how we can perhaps utilize retired nurses, nurse practitioners, even faculty, in creative ways, particularly to bolster the need for preceptor hours and things like that, because I think that we can do a pretty good job of perhaps offsetting some of the faculty shortages with creative use of existing faculty and technology. But that preceptor stuff and training our students to be ready to hit the ground running, that's the big. So I'm really glad to hear that. What Delanor said about what KNA is doing toward that effort. So, and that there's some funds toward that. So that's good. Thank you.
We have 1 minute left, and Kelly, I was just wondering if you might share some of the things that you've been sharing with the nurse leader group about what students can do to help in the environment to relieve some of the staffing issues, as well as help students to be ready to get started on day one when they graduate.
I think you're referring about our nurse extern model and regulations. So
yes,
I have been talking to many of the schools and different CNOs at hospitals. So we already have in our regulation where nurse externs, which they can begin after their first semester of nursing school, but those that are particularly in their last year of nursing school, if they're in a 4-year program, or in their last semester of an ADN program, can really function almost independently. And what these students can do is be support to the nurses out on the front line. So the nurses do have to provide supervision, but a nurse in their last year or last semester, they can do anything that they've been educated and clinically competent in school, and then they have to perform and get checked off once they're in the hospital or nursing home setting, but then they can actually do those tasks. It doesn't have to be hip-to-hip supervision. So plus it also helps the hospitals in order to recruit and retain these students after they graduate, because they've basically finished their orientation. We use those a lot in the hospital that I came from. So just a reminder that those things are available, and our students, most of them are eager and ready to get out into the workforce, ready to make some money. So it's actually a paid model. So.
Okay, thank you, Kelly. Well, it is 1:01 and we're 1 minute past our time. I want to say thank you to our speakers, Dr. Osage, and Dr. Estes and Dr. Melander. And thank you to all of you for joining us for this incredible presentation. And we will have, it is recorded and we will put it on the KNA YouTube channel so you'll be able to look at it and refer to it in the near future. Thanks again and have a great Friday.
Thank you all.